Hello, Alicia. It's good to see you.
Hi there.
Hi there.
Nice to see you.
Yes.
Hey everybody, this is Susan. It's Sarah.
Oh, it's Susan
birthday.
Matney.
Yes,
Yeah.
you got it. It's her birthday today.
Oh, it's my birthday. Thank you.
Oh, happy birthday.
Thank you. The big 5-0.
The big one.
Oh, it's a fun one.
I know.
If I sing you happy birthday, will you kick me off the call? Happy birthday to you.
Cha cha cha.
Happy birthday to you.
Cha cha cha.
Happy birthday, dear Sarah. Happy birthday to you.
Cha cha cha.
Thank you, Justin.
No, no, that's obligatory. Anytime I'm around somebody on their birthday, they have to suffer through that. So happy birthday
Thank you.
to you.
Jonathan, that was the wrong last line. Happy birthday, dear Sarah. How
Oh.
much we love you.
Aw,
Yeah.
Thank
No, that's
you.
good. Thank you, Lee, for the value of this offer.
Adding value to what you started.
That's consensus, friends. This is what we do here. I mentioned this earlier, but I'm going to state just for reference, whenever it's my honoring a birthday makes me think of my mom, and Asha knows this and Susan knows this, but I'm a cesarean baby, so I was a planned birth after a few complicated births, and my mother chose me to have me on International Labor Day because she wanted me to go out and work for justice and help solve the problems of the world. And I'm always like, ooh, she really set me up there.
Wow, she knew what she was doing.
Yeah, she was
you're doing it, man. You're living the dream.
I know. And she's like, I had a vision. And I'm like, okay. I try to honor it, Mama. All right, we are ready to go.
Sarah, I have to say that's a wonderful story, but I have to say also that working for natural vaginal birth has to be an extremely high priority for everybody who works in that field. Cesarean section is surgery. It's dangerous. It deprives the infant of what it gets as it moves through the birth canal. There's 1,000 reasons why C-sections are good for the mother, but not good for the baby. And anyway, we could spend the rest of the hour.
No, I know, and that's
so
why
I'm glad you're here, but let's not be promoting C-section. Thank you.
Well, and that's why I said it was planned, because my mother had some serious complications from previous births that it made her unsafe, but I existed. So she wasn't allowed.
That's a wonderful reason. I'm sure it was medically necessary.
That was
not what we hope will happen. Thank you.
Love it. We're starting out with some lovely themes at the beginning of our meeting. Welcome to the May 1st Gravity Public Call for Terminology. It's our honor to welcome you to the end-to-end review for our topics of reference. And next slide. Thanks for joining. Everyone is muted upon entry. And again, I'm going to say it out loud. Again, Asha and I are running the show without the amazing Sarah Bahal. So we're trying to both admit people to the call and put links in and move slides. So our apologies if things don't go as smoothly as they sometimes do. So everyone's muted upon entry. The call's recorded. Recordings are always available on the Gravity Confluence page after the call. Everyone's encouraged to actively participate by sending comments to everybody. And we do ask that things get sent to everybody because, we're trying to have an open consensus conversation here. Next slide. We are bound to comply to antitrust practices as part of our work here. So all participants have the responsibility to comply fully with federal and state antitrust laws. And we apply these principles quite generally. So not just direct avoidance, but also anything that might be construed as violating antitrust behavior. Next slide. Our agenda is brief announcements, and then we will go through a brief overview of gravity terminology and approaches in Gravity Project, and then into the work, protective factors, end-to-end review, toxic stress, end-to-end review, and racism end-to-end review. Next slide. Next slide. As you all are aware, because you're here, Gravity Terminology Workstream is meeting weekly now. It used to be that we met every other week. We did this to accommodate the breadth of topics we have to address in terminology right now, both new domains, and that's what we're working on now. And then we do our enhancements work on the alternating week. So today is new domain work, alternating call is enhancements. The technical work stream is always meets every other week, Wednesdays 1 to 2. Our next topic, oh, sorry, it's not, the next meeting is not on April 30th. That was yesterday. Sorry, the next meeting is 2 weeks from yesterday, but the topic will be social care capacity use case. Implementation Affinity meeting is planning for the end of this month and focusing on further topics on return on investment, specifically looking at patient and provider burden and how closed loop referral standards enable the reduction of this, and the evidence and research regarding that from some of our members. Next slide. Any questions on the agenda? All right, next slide. So Gravity Project fresh off the presses. The steering committee spent months revising the Gravity Project vision and mission. It's our honor to present them now. They were in process, but the vision is we are a representative and sustainable consensus community that's collectively driving social care data standards to support the goals of population health and health equity. The mission is we strive to enable health and social care organizations to readily share the information needed to effectively meet the social needs of individuals, to improve person-centered health outcomes in communities, and advance health equity by using standardized terminology and interoperable technology. Slight updates. We presented the old ones to you before. It's our honor to revise them. And our members, thank you so much to all the members who participated in the revision. It was a lot of work, and thank you to our PM, Corinne and Corey, another member of the amazing PMO. It was a lot of work. We're glad to get here, and thank you all for your input. Next slide. You all are well aware of this, not going to spend too much time on this, but health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. We do the work of addressing data, developing data standards to address the social determinants of health in this group, in our collective group in Gravity, including both protective factors of strengths, positive findings, and risks. Next slide. Our amazing sponsors, we're very, very grateful for our project sponsors. We include both the sponsors who give financial support and designated members in our model, adding new members all the time. Again, thank you so much for them. We wouldn't be able to do this without you. And again, the designated member model is unique for us within HL7 accelerators because it allows patients and community-based organizations to participate in governance, driving the Gravity strategy and roadmap from a social justice framework. Next slide. It's important to note that all work within Gravity is prioritized for the roadmap by Gravity governance members. And so it's a collective, includes every new domain, every new use case. It includes the work we're addressing today. It's a collective representative of the voted upon priorities of the whole body and not just one entity. The consensus by design and planning, as in our work here in the work stream. Next slide. Our principles, constant. We weigh them. Part of actually end-to-end review that we're in right now is actually thinking very carefully through our principles and the concepts we have at hand. Our principles are improving personal health outcomes, improving population health equity, ensuring personal control, designing appropriate solutions, ensuring accountability, and preventing, reducing, and remediating harm. Next slide. And then lastly, what are we doing here in terminology? Identifying standardized instruments that can be used to identify the domain, developing lists of diagnoses, risks, conditions, and strengths that need to be stated, thinking about the goals related to that primary finding, and then thinking about all the things we do to work to address either the risk or the strength in the intervention side. So this is the work of Gravity. In this work stream in the new domain work, it's a little bit different in the enhancements call, but right here, this is the work of the day. Next slide. All right, so we are firmly in the middle of end-to-end review. We'll go more into what end-to-end review is, but we like to say that we proceed in very formal fashions, but with semi-formal methods, because we really try to make everyone feel welcome and everyone feel like they have a voice within our meetings. But the end-to-end review is a time to start locking things down. We'll go more into what that means in the next slides, but all headed towards that end of May consensus vote on the work we've been doing since the 6th of February, right? We're many months in, we're almost to the end. And so we take the responsibility of looking at things from tip to toe, an end-to-end review. Next slide. So again, because of the breadth of content, we'll talk more about time management, just like we did at the other, in the last meeting in a few minutes, but we have a lot to cover. Addressing 3 domains means we have to be really prudent with time. So anything that's been presented, any instrument that's been presented prior won't be presented again, even though it's on the master. We're not going to be presenting general interventions that apply for every domain. We're also not presenting any existing intervention concepts that SMEs have determined apply to this domain. It means things we've already defined in consensus and identified. We're really focusing on new things in this call, newly identified concepts, definitions, and terms that we need our consensus group to nail down by the end of May. As always, everything in the domain, everything a subject matter expert has touched and you all have reviewed goes into the master files for consensus review at any time. We just had to make choices because there's so much to cover. Next slide. End-to-end review, the purpose is very intentional, methodical. We've developed a lot of things, a lot of concepts. We've identified a lot of programs, interventions. And so we sit back and look at the collective gathering in the master file, and we ask if things are missing. You're going to see some new things here today. So this is the subject matter experts identifying things as missing. We ask if things are incorrect that need to be changed. Again, looking at that master file, fixing wording, adjusting concepts. You'll see terminology take a lead in some of this, literally like taking the concept the subject matter experts want to say and making sure it fits into the confines of whatever terminology we're speaking of, whether it be ICD or SNOMED CT. And then whether there are things that are unnecessary and should be removed, right? And so it's a formal process. I want to thank some of you on the call for already submitting formal comments. We've gotten back to you. I think, at least I hope, all the comments we've gotten so far. So once we enter end-to-end review, really respecting the work that we've all done together, comments and edits have to be offered in written form with a rationale and evidence for the alternative approach. It has to be sent to gravityproject@hl7.org. We do log thoughts in this meeting, but formal comments that are going to be affecting the master lists need to be sent via email. And everything that you all mentioned gets pushed up to our subject matter experts to be assessed in relation to the work we have at hand. Next slide. Any questions? All right, next slide. Okay, 20 minutes. Again, we're going to try to do 20 minutes. So next slide. We're going to try to do 20 minutes per domain again. That worked well last time. There's not a lot of new content. Things are kind of stable right now. So hopefully we can give room to have, thoughtful conversation. We presented a lot of new content last meeting. So we're trying to do 20 minutes per domain, and then we'll be back in 2 weeks, and we'll back in 2 weeks again, and then we come back for the vote. So we have a lot of time to reflect on things as we go forward. Next slide. All right, into our protective factors end-to-end review. Next slide. I want to note that, again, I think I mentioned this last time, our protective factors friends and subject matter experts, originally we had it combined with toxic stress because it's so interconnected, and then we've actually isolated it specifically to really lean into that strengths-based approach. So within protective factors, we're naming the practice of working from strengths-based approaches. This is core to the work of nursing, core to the work of social work, core to the work of all kinds of professions, like strengths-based perspectives. And we brought in peer support this time because that's a lot of what peer support works toward. The aim is to name the strengths and assets we assess and foster to promote well-being, thriving, holistic understanding, and capacity. And then there's a lot of, we were actually talking about this as an internal team this morning. There really is a problem-based focus in most of the medical structure, in data classes and data structure and, in meaning. And so it's a fairly radical thing to lean into ensuring that we have, I'm just trying to, oh, Asha's entering, letting people in the waiting room. Thank you, Asha. So there are some technical things to think through when we think about how this intersects with naming strikes intersects within the architecture of terminology. And this is part of what we're doing as well. But we have a problem list in health records. We don't have a strengths list, even though we do strengths-based assessment as a core part of most of nursing and social work, like every day. Next slide. All right, assessment instruments. These are going to grow. We have some existing assessment instruments, and then we have some opportunities to enhance them over the course of the next weeks. We are meeting actually with colleagues in American Academy of Pediatrics and Bright Futures tomorrow, just honoring the strengths-based assessment that is core to all Bright Futures and American Academy of Pediatrics methodology. So hopefully more instruments in time. For right now, we have the next slide. We have the two kind of basic, just like with the racism domain, there are two core basic instruments that are kind of well known across the ecosystem, and it's the Protective Childhood Experiences Scale and the Benevolent Childhood Experiences Scale. Again, these were presented weeks ago, but more instruments might come in time. Again, they're all available on the master file in the Confluence. Next slide. We had to create a framework, and we presented on this last time, and probably this will be the last time we mention it. Our work towards developing our strengths-based terminology really was the intersection of at least like 6 different models of thinking through concepts, right? So this is the intervention framework. We'll talk more about the protective factor framework in a second. So there's like a radical way to like integrate the research behind strengths as we think about strengths and protective factors terminology, but we also needed to think differently about our intervention framework. Our current interventions that we have, we added adjustment in 2022, really are not sufficient to meet the goal of how we work with strengths in individuals. Just as you identify, if you're in social risks and problems, you want to mitigate the problem. In strengths and protective factors, you want to foster and promote it. So we'll be adding an additional intervention type to our framework to allow for that, the work of promotion, which is again, cross nursing, cross medicine, cross social work. It's everywhere, health promotion. So that's just going to be part of what we do in order to address the domain. Next slide. Next slide. So this is the framework part. I was getting ahead of myself. Again, subject matter experts and the terminology team really have married in, I think it's about 6 different frameworks and perspectives in order to get to the buckets of how we're thinking about strengths in our work. We're using these as rough placeholders for all of the concepts just to meet from a sufficiency standpoint and adding to it if needed. Next slide. So within the realm of structural supports, there's only one addition here. Again, we presented everything above last time. The addition is the protective factor of positive school environments. This is a direct protective factor critical in the work of Administration of Children and Families and American Academy of Pediatrics and family practice. The role of positive school environments as structural supports for kiddos. And so we brought that to bear, and it's part of the structural support section now. Next slide. There's a lot of, there's a slight edits and some new concepts in the social connection area. When we reflected on the feels connected to culture, feels connected to community, and feels connected to family, we're exploring how to name that it's one's own culture, one's own community, and one's own family. The one's own is kind of in flux, but the own part might be dropped, but it's not just culture in general, it's one's culture specifically. So we're exploring the one's own bit, and that's new since last time. We also have a few other new concepts in social connection. Satisfaction with school environment. That one, again, the wording might change slightly, but it's different than the actual structural support of the positive school environment for the kid. It's actually the individual's connection and placement and feeling well placed within that school. And then we have a couple new ones too. We have feels connected to affinity group. We brought that in because really from stemming and conversations about school environments and belonging and how people connect there, knowing it's not just academic, knowing there's also lots of like affinity group connections, whether it be Amnesty International or sports club or debate team or some kind of purposeful belonging. And so we felt the feels connected to affinity group is not just for kids important, but important for all of us. When we start to think about strengths, like having, a Tai Chi group, some kind of knitting club, things that gather you together for a specific purpose of reference. We brought in civic engagement, Lucy, trying to make sure that we have that civic muscle concept that you mentioned and the voting concept. So that one was brought in, but realizing that civic engagement is not just the only strength in that area. We had a long conversation on ethics, and there's an existing conversation about displaying ethical principles. And so we brought that in as well. So now within the civic muscle realm, we have being engaged civically, but also feeling like you're an ethical person and displaying ethics. And that seemed to cover the domain that we covered last time. And I saw a thumb, so great. All right, next slide. There's only one change here, which is that that gets 1 hour of physical activity every day, even though it's a very clear goal. It was not necessarily in keeping with the other concepts and not really identified as a strength when we felt like adequate physical activity and exercises regularly covered it. It is a very clear goal across the American Academy of Pediatrics, but we felt like it was represented elsewhere, so we retired that one. Next slide.
Sarah, what does athletic mean? You want somebody to feel athletic? What does that mean?
We'll create the definition for that. We really are playing with how, again, we're exploring how things like might be represented with other concepts. So maybe one of the things we're exploring is whether feel strong is actually the same thing as feels athletic. We actually are naming the things that we know patients and people say to us as strengths, right? And part of this work, like literal, like qualitative patients and people tell us these things from our professional expertise. That is something that individuals say on a regular basis, especially kids connected to sports teams and feeling strong, but definitions in progress, Lucy, and it might be represented in other concepts, just like we're finding the concept of resourceful represents a lot of concepts as well. More to come.
Thank you.
Yeah.
Thank you.
And I want to state, when I say qualitative research, there is a there's a question in the Bright Futures handbook, which is again the pre-visit questionnaire for every well child visit, as authored by the American Academy of Pediatrics, which asks, what are you proud of, right? And we've talked about this extensively in our work. And so those answers are people's strengths, like the things that they're proud of. And so a lot of the terms that we're coming up with in that work are really reflecting on the things people say in their own language when you ask what they're proud of. On the creativity slide, this is an example, Lucy, of what I mentioned. I hearkened to this. So we were exploring, again, how people report that they can fix things and they can make things. And we realized that was contained in the concept resourceful. So we are trying to be really prudent and only make concepts that, if we can make one concept that can cover lots of different minor concepts, we're trying to do that. So we developed the concept resourceful, and our sunsetting can fix things and can make things. Those were awkward anyway, but they were placeholders because they really are those, what am I proud of? I'm proud of X. And we realized the concept of being resourceful applies. We had a really lovely conversation on the breadth of resourceful across different populations and different settings and how it can apply. So resourceful can be very individual, it can be very setting specific, and it still represents a very similar concept. We also had a lovely conversation, I think, on when people say that, they're smart or they are, they're quick learners, how resourceful encompasses that as well. So again, really trying to be prudent about our language and not just create a proliferation of terms, and also trying to make sure that we're grounding ourselves in terms that have like evidentiary base. Resourceful is like a well-documented concept that we can defend with literature. So hope that makes sense. Okay, next slide. There's no change here. These concepts haven't changed since we were here. And again, we're exploring the depth of things like spiritual strength. That is an existing concept. So again, testing to make sure that that concept fits all the different ways that we think that spirituality is identified as being important to people. Okay, next slide. And there's a few things that were sunset here. So when we looked at this list, we realized competence without being defined is kind of vague. Like competent what? Like psychologically competent, physically competent. It was too unspecified. So we sunset that and are really testing to try to figure out what within competence seems like it needs to be represented. We felt like a lot of the emotional concepts are here. With resourceful, we now have the resourceful component of competence. And so we felt like we could retire that and put in better terms. I see Kwesi nodding, so hopefully I'm doing a good job for percent. Okay. Thank you, Kwesi. All right. All right, now next slide. And then there's a few more things in social emotional competence that we are exploring. There's a lot of things we're exploring in here. Reflective, able to verbalize things, efficacious, committed. These are all things that are kind of in the hopper, but we wanted to get them in front of you. Adaptive, emotional intelligence is one that's really salient. That's like a solid one. And then relational patterns is something we're thinking through. It's a finding that's critical. Kwesi brought it up from the social work perspective, but more to come there. So these are all things that, again, we're showing to you hot off the press, but they might be refined, especially the wording of some of these might be refined in time. Another thing I want to note that we talked through from a terminology perspective is needing to be consistent. So now that we have concepts, we're going to try to be consistent in how we state them. Like instead of like in some concepts we're saying able to, and in some concepts we're saying emotional intelligence is a thing, right? So we're going to take our terminology lens to it too and try to have consistency in how we're representing these concepts as well. All right, I think we're doing good on time. Lucy, yes?
Yeah, I'm wondering about reflective and efficacious and so forth. Is this self-attestation, I think I am?
Yep.
Or is this a provider or a clinician observing that the patient or the client in front of them is these things? I think these are different, because I can affirm, oh, I'm really self-reflective, and you can hear in my answers to questions or my descriptions of my experience that I'm clearly not. So I'm wondering whose opinion are all of these things?
I'm going to have maybe some of our social worker friends weigh in here too, but the way this goes down in practice on the normal level, right, is if a patient identifies that they have a strength and I feel like that's interesting, we have a conversation and we explore it. And I say, oh, tell me why. Tell me why you feel like this is the case for you, right? So my perception without their unpacking it is not sufficient, right? And if there is something to be explored there and they're like, actually, I take it back. I'm actually not really reflective. I think I'm more curious. And I'm like, great, right? So just like any other assessment, this concept is the end of a conversation and assessment with a patient presenting something and the provider going back and forth and, you know, jointly creating truth, right? Kwesi, is that fair? I see Kwesi nodding. Okay.
And the thing I'll add there is that what confuses that slightly is a concept like feels a sense of purpose, which is more to what
Yeah.
Lucy is saying. That's patient perspective. So if that was sense of purpose, then each of these would then have whoever feels it applied to them. But there's a bit still here of work we have to do.
Yeah, and that, Monique, that 100% relates to the consistency, right? Like we're not consistent yet in the way we're stating these things, right? We have feels, right? And then we have the concept. So more to come, Lucy. But did that answer the question
Thank
of
you.
how we arrive
Yes.
at them? Yeah.
Yes.
Yeah. Great.
Definitely. I have to say that I have never personally experienced as a patient or client anybody talking to me about any of this. So it's all new to me, the idea that an actual visit that somebody might pay for is going to get into all of this in the 15 or 20 or 45 minutes allocated. So thank you for continuing to think about this and how it can be actualized.
Well, great. And I just, that's it. That's fascinating. And I mean, I told you that it's part of every single well visit that I do. So I'm like, it's also like a core part of therapy, like counseling is identifying strengths usually, right? And it's actually a fundamental role, just noting like where this happens every day, every single care plan on each one of my patients across every single setting in my federally qualified health center. So every patient in care management has a care plan. All high-risk patients have a care plan, or anybody else who wants to be part of care management. Every single time there's a list of strengths that they're identifying that the care manager is helping them work towards. Right. Yeah. So Marianne's like, great. So just note, Lucy, it's like, so it's interesting that, I mean, so I only say that to say it's happening all around us, right? In like weird little ways, and maybe not in the provider visit that you have, right? It's very, very strong. It's present in all of the care plans that we do and usually. And
And
it's
this is true of all FQHCs or just
no,
the
no,
ones lucky
not.
enough to know you?
Well, no, I'm going to say that if you look at the NCQA requirements for a care plan to meet the patient-centered medical home model, strengths is in there as a core requirement. I'm not saying everyone's doing it.
Okay, thank
But
you.
I am saying if you are a patient-centered medical home and you're developing care plans according to the NCQA PCMH practices, identifying strengths is a critical part of that.
Terrific. Thanks so much.
I'm happy to, yeah. Oh, and so yeah, so mental health providers definitely do that, and yeah. Or maybe you haven't entered care management yet, right? Like not everybody is in high risk care management. So if we're all lucky enough, if you're lucky, and then I am going to go back to the fact, and I know we're time, actually we're doing okay in time. I am going to go back to the fact that it is like fundamental, and I have my amazing colleague, friend Alicia here from American Academy of Family Physicians. It's fundamental in pediatrics and family-based care, like identifying strengths in kids and families and working. It's part of what we do. Like you can't, so that's just a core, which is why the American Academy of Pediatrics has it in its pre-visit questionnaire for every kid and every parent. But more to come. All right.
I'm really glad I raised this, Sarah, because some of us on this call are way too old to have ever experienced this with pediatricians when we were in contact with them. Thank you.
Yeah. And some of us are AAP nerds. I must admit I am one. All right, next slide. So these again go back to what I've mentioned before. So if you look across the literature, the American Academy of Pediatrics, American College, the American Association of Family Physicians, the Administration of Children and Families, everyone who works with kids, right? There's a core part of strengths, which is looking at family strengths, right? Because the kiddo is growing up in the environment of the family and the strengths and patterns of the family, and like underwrite the health of the child. So in addition to all of the individual person level strengths that we just mentioned, a core part of all of it, whether it be Head Start or whether it be pediatrics or whether it be, even education, is understanding the strengths of the family and fostering those as well. Most of the concepts that we have presented so far, if you look into the literature of the Administration of Children and Families, and I think we have this on our roadmap, are like, even though there's there's not necessarily, people don't study strengths as much as they study problems. But Administration of Children and Families has very clear directives that with kiddos with teen pregnancy, these are the strengths that are most critical to fostering better outcomes, right? Or with a homeless adolescent, these are the strengths that are most important to foster towards better outcomes. So there is ton of science in parents and parenting and childhood development that underwrites this as well. This is again from, direct from the American Academy of Pediatrics, protective factors framework work. So demonstrating knowledge of parenting, knowledge of child development, parental resilience, and not just child resilience, and then all the core attachment concepts. Next slide. All right, next slide, goals. Tricky. So we've been working from a deficit-based perspective until this domain. This is the first time a domain has been specifically focused on strengths. So in prior domains, we created goal concepts for the positive balance of a negative risk, like food security for food insecurity, or stably housed for housing instability, or feel safe in the presence of elder abuse and IPV, right? Where are we moving forward? These concepts represent the desired state of what we're aiming for. With the protective factors, the positive finding, resourceful, is the principal finding. It's the thing we're assessing, right? So there is no opposite for the goal. The goal is just more of that. We talked about promotion, right? So it's fostering the strength. It is like the gardener nurturing the person's sense of belonging to community, right? So our job with strengths is to take what we have, that germ of the strength, and just help it be stronger. And I see Questy nodding. Maybe he's okay, I'm good. I have my social worker like right there. No, having his nods. Okay, this is the nurses and social workers. This is our work on a daily basis. And so it's not appropriate for us to develop new concepts for every single one of the strength findings, right? That would just be redundant, like more resourceful, more connected. And so we are leaning and exploring how to represent moving towards better in other ways. There's lots of standards to do this. If you look in the literature of care planning, Lucy, there's this thing called goal attainment scaling, which we use in care planning on a regular basis. Like a patient, if you're working with a patient, you're setting a care plan, and they say, I want to be here when I come back to you, right? And when they come back to you, you talk with them and you're like, so are you where you thought you'd be? Are you better than where you thought you'd be? Are you worse than where you thought you'd be? And that's the goal attainment scaling. There's a Likert of where a patient expects and thinks that they are going to be in relation to that goal. What if you don't find strengths or not enough of them? Yeah, you can imagine that too, Lucy. Like if that's how we've modeled strengths in the past, right? Like our sneaky way of getting protective factor language in from like a deficit-based perspective was building the strengths and protective factors as the goal. We have a mine of goal concepts and protective and strengths concepts from our prior domains, right? So certainly if somebody, and this is again, counseling, social work, nursing, clinician, we do this all the time. If someone's moving is truly in like a deficit-based space, we yeah, Marianne, it's certainly that's another way to say it. But anyway, we sometimes setting, I want you to feel resourceful is the goal, but that's from a different spot, if that makes sense. And again, that's the work we do in counseling and nursing and social work and holistic whole person care all day long. I hope that makes sense. So anyway, instead of building like duplicate terms, we're exploring how to represent movement, improvement in other ways in the model. And there's lots of great precedents for this. Does that make sense? Okay, because we're just going to be resourceful with a description, hypothetically, but definitely not multiple new terms for all the things we're creating, because that would be too much. All right, does that part make sense? Resourceful is the finding, resourceful still the goal. We're going to measure how are you moving towards resourceful in other ways without creating a duplicate term. Okay, next slide. All right, so we're on time, which is amazing. Moving into our toxic stress physiology end-to-end review. I'm still talking a lot, but we have a lot to do. So next slide, we've got it. Next slide. No changes to instruments. These have all been constant for some time. You can find them all on the master lists. Next slide. Next slide. We have some changes to diagnoses. It's always, we did this last time, we're going to do it again. It's really important when we head into this work that we ground ourselves again in what those core categories of adverse childhood experiences are. Right? We're going to take a breath and level set. So they are concepts in abuse, physical, emotional, and sexual abuse, concepts in neglect. And again, this is a huge switch. I'm sorry, I didn't prep us all. I just went straight through. Moving from strengths-based affirmation into toxic stress is a shift. I'm just gonna, that's why I took a breath here. And then there's concepts in neglect, physical and emotional neglect. And then there's concepts in household challenges. The most the most significant gap, I shall say, in terminology represents these, right? So there's two different ways that we talk about diagnoses in relation to toxic stress. One is regarding the algorithm for levels of toxic stress risk for toxic stress physiology related to the algorithms and evidence of adverse child experiences. And then other is specifically ensuring that we can name each of these 10 categories. And we're aiming at naming each of these 10 categories, not from both in the moment with the child, right? And from the adult looking back, right? So that's our work in diagnoses, ensuring we represent risk for toxic stress physiology and ensure we have terminology to document each of the core 10 categories, both from current childhood experiences and adult look back. Does that make sense?
Sarah,
Okay.
would it make sense to add to the title here, and I'm just groping for the right language, in children and adult look back? Because this title right now, to me, evoked a child in front of you and you're alert to these potential adverse experiences. The adult look back, all of this is going to apply, and I'm just struggling with whether it's needed or useful to remind anybody looking at this slide that we're not just talking about children.
I can think about it. The interesting thing is that the focusing on children in the moment is the new part. So historically, it has been adult looking to adults and thinking about childhood events in there. But I hear what you're saying. We do differentiate that in the upcoming slides. I'll reflect on whether we can improve the title of this slide.
That's fine. Okay.
Yeah. Next slide. So this is the risk of toxic stress physiology. These have not changed, right? So that these are pretty constant from our meeting a couple of weeks ago. Next slide. These again are pretty constant. They haven't changed. This is the history. Again, these are the adult look back concepts. Here I can make it a little bit clear. We can say adult look back, Lucy. I said history of, right? But I can also, I can change the slide to be adult look back. And these again are with the adult documenting specific, those 10 categories that they experienced as a child. And these are the abuse concepts. Next slide. And then this is where we get into having to create concepts. And we're working again with our colleagues who are SNOMED experts. Like we have the amazing Monique Van Berkem on the call, but also our ICD-10 CM specialists who are not in the meeting, but usually are because they're all away at a meeting together, documenting specifically and clearly the household event, right? So those categories are at the household level. My first take was just awkward. And so what we've gotten to since we last presented was clearly this grounding of clearly identifying that it was an adverse childhood experience. So personal history of adverse childhood experience. And that personal history is the precedent for it happened to me in the past. And then the syntax being the comma, the specific category finding. So personal history of adverse child experience, household member separation or divorce. We did clarify very clearly with our SMEs that they're adamant that the family concepts are not sufficient. And we had a brief conversation on this in the 2 weeks ago, because the confusion of like family being beyond the household and the ACEs categories being clearly about what's happening within the household. And so we're doubling down on the fact that it has to be household level. There is precedent in ICD to document household level concerns, but you can see that syntax playing out across those next concepts. So the pattern is the history of adverse child experiences, comma, and the unique ACEs category. What we presented this part, we did not present the child concepts, the happening currently to the child last time. So that's new, and that's on the next slide. So in addition to the look back concepts, like I have a history of being a victim of physical abuse as a child. We have to be able to name the findings and the 10 categories when they're happening in the moment. And these are the current abuse concepts that relate to the 10 categories if you're documenting the abuse in the moment in presence of the child. Lucy?
In the previous slide, I think the last 2 rows were,
Oh, they're duplicates. My apology. That's me. I have a
okay,
transcription
that's
error.
it.
Yeah,
Thank
you
you.
can see I didn't, that's me. And all the things. That's my fault. Thanks, Lucy.
You know you're up
That
late
slide, so
doing
you can
this.
see, yeah, I'm
You're up
totally
late doing
falling on
this
my
all the
sword.
time, Sarah.
Yeah. All right, so these are the current childhood concepts. It makes sense, right? So if you're investigating and supporting a family and understanding and doing an ACEs screener, and they've identified that there is a concern for current abuse, which is what an in the moment ACEs screener would do, documenting that is critical. ICD is tricky when it comes to abuse concepts in the moment, as opposed to history. There's always a suspected concept in addition to confirmed. We just put the confirmed here. You'll find the suspected on the master list. But again, these are all the specific abuse concepts that are happening in the moment. Next slide. And then this is the correlate of those personal history concepts, but in the moment. So it would be documenting the adverse child experience, household member separation or divorce. I didn't carry that problem over, Lucy, this time, specifically intimate partner violence and household mental illness or separated. I just messed it up on the previous slide. And again, this was the decision of the subject matter experts. Again, thanks to our terminology team for assisting, clearly naming that these are ACEs and in the specific category of reference. Because adverse child experiences are international, it might be that these terms are appropriate for international ICD, because the adverse child experiences literature, just like some of our other literature and social risks, even though it came out of the CDC Kaiser study, has now been disseminated across the world. So this is our approach to the diagnostic concepts for the household member categories, in addition to the risk stratification. All right, any questions here? All right, next slide. Next slide. So we have, this is totally work in progress, but we wanted to get it out to you. So one of the goals is very, very clear. The team was all the subject matter experts want to be able to clearly demonstrate that someone understands how toxic stress physiology plays out in the body. And this is work that, the practitioners in the room all demonstrated as core of the practice. Like if you screen for ACEs, you inform the family of why, you talk about toxic stress physiology and how it plays out in the body. And so ensuring that the person you're working with understands how that plays out is a core goal, no question. We had a very interesting conversation a couple weeks ago, and then again on Tuesday, about what is the goal other than understanding toxic stress physiology. And it was a very interesting, and Kwesi can testify, it's a very interesting conversation because we've talked about the antithesis concept again. So if we have the risk and the risk is at risk of toxic stress physiology, we've been leaning into what is the opposite of that, right? And it's been a tricky conversation. So at heart, and this is again led by, we had this epiphany, kind of led by the brilliance of Dr. Nadine Burke-Harris, who is the former California Surgeon General and, like preeminent expert in this area. It goes back to those adverse childhood experience associated health conditions. And the presentation that we had, that Mackay presented to at the kickoff of the ACEs, from the ACEs domain, details what those conditions are, and it's all part of that toxic source physiology algorithm. Like, what ACEs do they have? Is there a presence of an ACEs associated condition like anxiety? There's hypertension. There's a whole host of conditions that are associated. And so the ultimate goal, like one of the ultimate goals, is that adverse childhood experience associated health condition not existing. It is difficult to figure that out in terminology. And so it's hard, right? And so there is the prevention of it in the first place. Like, that was the epiphany from the subject matter experts. The ultimate goal is to prevent the development of conditions that are born out of toxic stress physiology, right? And so we're playing on how to represent that. We have some ideas here. Again, all kinds of terminology work to do on these, but this is the rough path forward. Yes. The absence of, is there a question mark as in?
No, I'm saying, like, can you be like a statement, right? So can you just like reverse engineer it instead of saying this is present, saying the absence of this?
Yes. Yeah. And there's better ways to model in terminology. Usually you say no, this, right? But we'll get there, right? And so, but basically what the subject matter experts are exploring now is both representing preventing it from the beginning, representing when it's resolved and disappeared, and representing when it's improved. All tricky when it comes to terminology, but those are the three things they leaned into. We want to, like, an ultimate goal is prevent the anxiety from even happening in that 3-year-old kiddo who's in the household with these problems, right? The other is take the teenager who has anxiety because they're growing up in this environment and help them put that anxiety into remission or make its severity decrease, right? Does that make sense?
It
So-
does, and I don't want to hijack the conversation, but I think that part of the challenge is between the ages of 3 and 18 or even 21, like the formative years of development and communication skills, it's hard for them to be able to contextualize that. Does that make sense?
I mean, this is like what the ACEs Aware model is such a beast at, is actually showing how you can prevent it. And that's partly what Mackay was talking about, how the amazing thing in the way California's operationalized it is you get to qualify for enhanced care management. We were talking about care management earlier. Wraparound services, complete support before you even have a problem, right? So what California has done with this version, and this is what Nadine tries to disseminate across the country, is if you have a high ACEs score, even before the kid has any pathology, they get all of the services as if they did. Because the idea is to try to give them all the resources they need to thrive. So luckily the ACEs folks are experts in this. But yes, principally prevention, improvement, and resolution are the things that we're playing with. It's just tricky from a terminology perspective.
I would just say, in my experience as a case manager, is it's hard to not infer or project, right? Like, somebody doesn't have the words to actually express something. And so I think the difficult part is framing it in a way so that you're not leading them to a false conclusion without mitigating them from actually being able to speak about what's happening. Does that make sense?
Yes, I hear. I think I understand. The devil's in the details, Jonathan. I think, yeah, we're the complexity of actually doing this work well to improve the lives of the individuals we're talking about is definitely understood. Like, if that's what you're saying. Okay, great. All right.
Sarah,
Yes.
Sarah, I would just point to literature maybe 40 or 50 years old now, research documenting that adverse childhood experience like starvation during wartime, which I haven't seen on any of our lists, and maybe it doesn't belong, but the physiological result lasts a lifetime. So I am hoping, and please convey to the SMEs that we're depending on them to document that what research has shown about deprivation or ACEs during infancy can be ameliorated or resolved or overcome. Is that a scientific truth?
Yes.
Okay.
There's also, I want to note too that there, I mean, luckily we have all the science in the room in that meeting. I can assure you it is, and it's so
I'm
much
sure you
so,
do.
yeah,
I'm
so
sure you
much so
do.
that it's very difficult. Like, so it's such, there's such an adherence to the science that things that don't fall within it are, don't come out of this meeting. And the subject, and everyone on the call can attest. But I just want to note that that's partly why it's not the absence of toxic stress physiology. Sorry, it's making me emotional. Is like, because that, just because it's like we were talking about pre-diabetes in the meeting this morning. Like like the person can still have significant effects of toxic stress physiology in the body. Like the body carries the score, that amazing book, right? But they don't have associated health conditions. Still, the absence of those health conditions is a goal, right? We're not
Oh,
saying,
that's
yeah.
great.
Does that make
Yes.
sense?
Okay.
Okay. And we're going to be talking, yeah, okay, great. Next slide. Whew. All right. Interventions, there's not a ton new here. I don't think so. Next slide. This is all based on the science of what actually works to address the risk of toxic stress physiology, Lucy, like evidence, 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 gorgeousness. Next slide. So we have education concepts, and again, these are all related to the concepts and interventions that are known to address risk of toxic stress physiology: sleep, relationships, nutrition, activity, nature, mindfulness, mental health care, and then we have the education about toxic stress physiology and general concept. Next slide. Again, these are the same concepts we had before. That brings in the addition to the intervention framework, the promotion concept. Next slide. These are not new. We have used adjustment in the past, talking about adjustment of clinical care plan to address social risks. We have a specific one that our subject matter experts requested for toxic stress physiology, because this is actually something that happens in real time all the time. If you know a person's coming in with significant burden of toxic stress physiology, you literally adjust the medications you give them with that understanding in mind, or you address the treatment plan to accommodate that. Dr. Brooke Harris has an amazing ADHD example that she brings up every time. Next slide. Any questions on toxic stress physiology? Again, not a ton of new content. Grateful for all of you. Lots of the biggest thing was in those current category concepts. We're doing great. All right, next slide. We're now moving into the racism topic, end-to-end review within racism. Again, so grateful for our amazing subject matter experts for helping us guide this work. Next slide. Next slide. Our instruments still have not changed. I mentioned this, similar to the adverse the toxic stress and protective factors. Uniquely in these domains, there really are instruments that are evidenced and are gold standards, and so there was no need to add additional sets to the pool, and these have not changed for some time. Next slide. Next slide. Notably, we've reviewed this in the past. We highlighted the racial and ethnic concept because Williams and Collins' seminal definition of racism includes both racial and ethnic discrimination, which means our approach to this domain includes both as well. And you'll see that woven through the concepts that we have on the following slides. Next slide. Next slide. On to diagnoses. And so we are naming we're developing concepts for the broad experience of racism, developing concepts about trust, and we're really now presenting some new findings, some new concepts that came out of our subject matter expert work regarding racism and its effect on outcomes. Next slide. We have racism concepts, and then we also have we presented the internalized racism concepts a couple weeks ago. We are adding these racism concepts because we realized even though we were leaning in to the way internalized racism affects outcomes, we couldn't neglect to name, of course, how racism affects outcomes. We also unpacked what we meant when we said outcomes. So the subject matter experts spent a fair bit of time really thinking about the 3 principal outcomes that they felt like needed to be named. And they are effects on patient autonomy, effects on respectful care. And you remember maybe that respectful care was one of our goals, highly evidenced practice. And then racism affecting delay or denial of service. So in order to be very specific and clear about the outcomes that the subject matter experts felt like needed to be named, they named patient autonomy, respectful care, and delay or denial of service. Next slide.
Sarah,
Yeah.
sorry about that previous slide. This is such a profound thing to think about. What about racism in health insurance coverage? Does that belong in here? Because if you don't have coverage and you don't have the money to pay, none of this is ever going to come up because you're not going to see anybody. So,
Lucy, yeah,
okay.
that ties in directly to so our subject matters are very careful to weigh on things before they come here. Our next area, we're working on areas of structural racism right now, and also working on the chronic stress of racism. And so both of those things are incoming. Our SMEs are directly reflecting on them, but definitely healthcare coverage, wealth, housing, naming all those structural forces and how they play out is part of that work.
Thank you.
Next slide. And so this is where you can see all we had before when it comes to the outcomes was that internalized racism of service provider affecting care outcomes. And so this is again where those same, they unpacked it to lean into patient autonomy, respectful care, and delay or denial of service provision. We're still trying to figure out how the generalized internalized racism concept will be named, and if it even is needing to be named. End-to-end review allows us to pull things back, and then we have those trust concepts that have not changed for some time. Next slide. Next slide. There are very minimal, deep approach to the goal concepts that adaptively coping is a goal. I want to note that high effort coping and John Henryism is something that the SMEs are weighing right now when it comes into understanding chronic racism. So even though we have adaptively coping as a goal, you might see concepts come in that are findings reflecting the labor of coping over time and how it affects the body. Lucy, again, that the chronic effect of the stress bearing out on the body. And then we still have feeling safe, respectful care, and collaborative care, and then a concept and accountability. Next slide. Just note that we mentioned that we are centering the organizational level concepts within the Joint Commission. We're still working with the Joint Commission. They name and have their anti-racism system level goals that are common throughout the ecosystem. We won't necessarily build terminology for them, but they definitely exist as accountability levers. Next slide. There is not any significant change in the intervention concepts within racism. Lucy, we did not have time to address the nonprofit board concept in our meeting on Tuesday, but I hold space for that. We did not forget it. But these concepts are concepts that we brought to you 2 weeks ago. Next slide. All right, how is everyone feeling? Any thoughts or questions? Again, we're presenting only new things or things that we are defining here today. The master lists that are going to get posted tomorrow, at the end of the day, have everything the subject matter experts have vetted for these domains. Janice?
Yeah, could you go back to that previous screen?
Yes, 100%.
I was glad to see patient advisory board here, but and communication resolution programs, that's good. Like restorative justice kind of things maybe. But I was wondering if like CBO, not only patient advisory board, but community advisory boards, if that's already included somewhere, or if that will be included in this, because uh more and more I'm seeing organizations are including community members along with patients.
That kind of relates to what Lucy was bringing up. We'll pull that into our theme on examining nonprofits and the places patients go for advocacy and concerns related to that. It makes a lot of sense, Janice.
Yeah.
Thank you.
Sometimes they're not a nonprofit yet though, and they
Yeah.
become one. Like Seattle has actually sponsored a number of organizations during COVID in particular, addressing these issues after, what happened during COVID, and they funded them even though they weren't actually a nonprofit.
Wonderful. I appreciate your boots on the ground understanding as always, Janice.
You can always learn more.
I know we can always learn more, and you help us learn more all the time. Any other thoughts on these domains? So we're in end-to-end review. So if we go to the next slide. Next slide. We have jobs to do. I'm assigning you all jobs. So in end-to-end review, it's each of our responsibility to ensure that the master lists are sufficient and ready for the vote at the end of the month. It's now May. So within the month of the consensus vote on May 29th. And so we want you, when tomorrow the master lists get posted, Sarah B will post them by the end of the day. And so ahead of our next meeting, please review the master list and reflect if there's things that are missing, if there's things that are incorrect and need to be changed, and if there's concepts that are unnecessary and should be removed. And not just unnecessary, I want to note again, I mentioned this in our principles, but if a concept seems like it's offering more risk than benefit, let us know. All comments in end-to-end review are formal, so please send comments to gravityproject@hl7.org. Again, with that rationale for why it needs to be changed as part of that. Thank you all for coming on this May day. And we look forward to seeing you again in 2 weeks. We only have a couple more meetings before we head into the consensus vote. And we're so grateful that all of you came today.
Before we leave, Sarah, what are you doing for your birthday? What are you doing for yourself for your birthday?
I am going to dinner with my kid, and then I'm having lots of Gravity knows this, the team. I'm having a party for myself on Saturday. I throw myself parties.
Happy, enjoy your birthday.
Yeah, I ran to the lake like I always do. I'm gonna go sit in my garden, take a nap, maybe. I already took a nap. Thank you all.
Happy birthday, Sarah.
Happy
Thank
birthday, Sarah.
you. Thank you so much. Thanks for being my Gravity family.